Hello, everyone. My name is Amanda Furland. I am a doctor of physical therapy coming from the United States, and I'm also clinical faculty for Chongji University here in Shanghai, as well as the University of Southern California. And my colleague and I, Paul Hartman, have put together a series of post-operative presentations, if you will. We've been presenting these live over the last several years here in China. We've both been working in China, in my case for almost 5 years, and Paul's case almost 4 years, in Beijing and Shanghai, with the idea of helping to improve knowledge for physical therapists, specifically working primarily with orthopedic patients. And so what we have recognized is that surgeons and doctors in China are very nervous about allowing their patients to be seen following surgeries because they are not confident that the clinicians that would be working with these patients would be able to understand the surgeries as well as understand the best way to perform rehabilitation. And so once us at the University of Southern California sort of recognized this need in China, we put together these classes. And what I'd like to do today is just spend some time discussing the primary principles of tissue healing, which is something that I think is lacking in China. And I know you guys get so much great education about certain things related to anatomy and maybe even just smaller pieces of the puzzle related to rehabilitation. But what I'm hoping that I can express to you all today is these bigger ideas about what tissue healing and specifically tissue loading looks like, so that you can understand how important that is following any injury, and specifically in the case of these classes, post-operative injuries. And so you'll see here from this slide, we're going to start with injuries related to cartilage and meniscus. And the reason that we do this is because cartilage and meniscus tend to be the most difficult tissues to heal well. And we'll talk about that a little bit more in a couple of minutes. But you'll see that we're going to go from cartilage and meniscal disorders to ligament disorders, and then tendon, and lastly bone. And I have recognized in China that people tend to focus a lot on fractures. I think part of the reason is that we see a lot of fractures, but also it's because fractures, which you will learn is actually the easiest tissue for healing and the least complicated in terms of what we do. Unfortunately, those patients who have had fractures are immobilized for long periods of time. And so I'm sure if you've practiced in rehabilitation for any amount of time, you have seen that because of this immobilization, these patients are much harder to rehab. And I have been so lucky in seeing over the last 5 years or so that a lot of the surgeons and orthopedic specialists in China are starting to recognize the importance of loading, of changing mobility more quickly. And so hopefully the trend will also change and become more like what we're seeing in the West in allowing patients to move more quickly. And so again, what I would like to do today is focus on the principles of post-operative rehabilitation. So this is something that you are going to see over multiple presentations. We're also hoping to be able to give you specific case examples with patients and also perform some sort of lab that allows you to better understand specific treatment for these patients. So again, today's introduction, we will do the next video specifically related to the biokinesiology and management of cartilage and meniscal disorders. But today I really want to discuss the overall principles of what all of these classes, what all of these videos are going to look like. So what you will find is as we present each of these post-operative videos, as well as each of the tissue disorder videos, is that we kind of follow the same format. And so each of them will look somewhat similar. It's important, of course, for you to understand basic anatomy as well as biokinesiology. And so as we work through each post-operative rehab protocol, if you will, we will start with anatomy. We will also discuss the principles related to how these injuries happen, but then also understand when surgery is appropriate, and then understand the surgical procedure. So whenever possible, we will actually provide you with a surgery video of some kind, and when it's not possible, we'll just discuss the actual surgeries themselves so that you can understand how surgeons are performing what you will see then in rehabilitation. So again, we're expecting you to also be able to understand the tissue that's being stressed. So as I said earlier, is this tissue a cartilage or meniscus? Or is this tissue a ligament? Is this tissue a tendon? Is this tissue bone? Because each of those things are going to be different in terms of how they're dealt with. And the last thing we also will talk about is muscle. And we're talking about muscle usually with relationship to something like a tendon, because muscle, as you will see, is actually something that heals very quickly and relatively easily. So once we discuss the actual surgery itself and the tissue involved, then we will talk about how you can figure out the appropriate level of stress that can be used on that tissue and what the time frame will look like to allow for that stress to improve healing. So there's different amounts of exercise, there's different amounts of manual therapy, even modalities, which we're not going to talk a lot about modalities, but even those things need certain amounts of intensity to allow for better healing. So we will talk about that. We will provide you with timeframes for different phases of treatment. And so what you need to understand is with cartilage, and actually most of our tissues, in the early phase, we need to have more protection. So we call that first phase the protection phase with all of our patients. So following surgery, we do need to protect the tissue. And different types of tissue need different amounts of time of protection before we can start doing a lot of loading. So let's talk about tissue loading, because that is sort of the main principle, the main idea that we will be discussing today. So what you need to understand is that stress, as long as we are putting stress on the tissue gradually, it's actually a stimulus to allow for further tissue proliferation. So specifically chondrocytes and fibroblasts, which are part of tissue development, have increased activity when we provide some sort of stress. And as we talk about each tissue, we'll talk about how that works. But what this does is it actually improves the integrity of the tissue. So by providing stress and not just resting through tissue development, we actually make that tissue stronger. So what we talk about is this idea of cyclic loading. And so for cartilage specifically, what we've found is that if you continue to provide very low stress movement, that tissue adapts and actually improves its strength. And this is a huge and important idea to be able to understand related to all tissue. And when we talk about cartilage, we talk about what's called cyclic loading. And so we'll talk about that more specifically in the next set of slides in the next recording. So what does cyclic loading look like? Just as a basic idea, we can do cyclic loading by just performing range of motion. So we don't want large amounts of shear or compression, but what we want to do is just perform range of motion. As we talk about different types of tissue, we're going to talk about what that range of motion is. Is it passive range of motion? Is it active assistive range of motion? Is it active range of motion? Because you will see with things like a tendon, if a tendon has been repaired, we don't necessarily want to perform active range of motion for several months because we need to be able to allow that tendon to heal. However, passive range of motion without contraction of the muscle and therefore without any strain on the tendon is absolutely okay. With other types of tissue, we actually can perform more active or active assistive range of motion earlier because it's not going to affect the tissue. So obviously with a bone fracture, there's nothing wrong with doing active range of motion because it's not going to change that fractured tissue. That fractured bone is going to still be able to heal. So these are the kinds of things that we need to consider when we consider how we work with our patients following surgery. You'll also see that we can perform things like manual therapy, soft tissue mobilization, and even joint mobilization at certain periods of time throughout a patient's treatment. And then lastly, as we start getting more advanced and as tissue is healing more, we can start performing more advanced activities. So dynamic stabilization, dynamic then mobilization. So those more dynamic movements are allowed later. But we can start progressing exercise, again, at different time frames, very dependent upon the tissue. So this just provides you with a pictorial representation of what those different types of loading look like. And I'm also going to show you all a video of what that looks like. But what you can see here is you could certainly use things like manual therapy. Oftentimes we'll use electric stimulation. You'll notice after surgeries for things like an anterior cruciate ligament repair, sometimes a hip replacement, knee replacement, multiple surgeries that you're probably seeing every day. I'm sure you've recognized that the quad muscle, especially the quadricep muscle, does not remember how to turn on very well. So sometimes if we're seeing them several months after a surgery, and if they haven't been using, let's say, their quadricep muscle, then that muscle itself actually becomes atrophied, and we'll see a much smaller muscle. But if you are lucky enough to see a patient immediately following a surgery, you usually will not see that the muscle is smaller, but instead what you'll see is that the muscle is not turning on. And that's a different problem. That's really just more related to the brain not having a good connection with the muscle because of the trauma of surgery. And so what we need to do is use something like electric stimulation, also just use attempted active contraction and do that over and over and over again to help with basically neuromuscular stimulation. It's more of a movement pattern problem or a muscle contraction problem. Even though the muscle itself is plenty strong, it's just not turning on yet. So that's another option for loading. There are also things like shockwave therapy and obviously exercise. So as physical therapists, you guys will recognize as personal trainers, as people who are working with these patients after a surgery, you will recognize that these patients need exercise. They probably don't need to look like our amazing weightlifting girl here in the picture, but they need something. They need to start moving. And what we're hoping that you'll recognize is that there are lots of options for loading. We're hoping that as you go through this class, these different segments, that you'll be able to be more informed and more prepared and confident about figuring out the best ways to load your patient. And then also being able to sort of help your doctors understand that. So provide them with references so that they can understand that these different options for loading are good. And again, this class is really all about finding how to load optimally. How can we do this? What direction, what magnitude, what frequency, how long should we be loading them to allow for this patient to get back to their normal function as quickly as possible without hurting the tissue. So that's our biggest goal. And so again, we will provide you with timeframes and knowledge so that you can understand that. And you will also see that there are definitely a lot of situations, unfortunately, where we don't have all of the knowledge. And we have as much as we can use at this point, but you're going to see where the research is really great. Let's say for something like an ACL repair, there's so much research out there. But if you're somebody who's working with something like a tibial plateau fracture, which is very common here, or maybe a pelvic osteotomy, also very common in China. Some of these other things like, it's hard to say, but other things that might be surgeries that unfortunately do not have a lot of research. And those are the things that we're hoping that you see it and you say, oh, well, this makes sense. What I'm learning in this class makes sense. And so I think we need to do more research to be able to convince my doctors that weight bearing, even after a hip fracture, I'll tell you, oh my goodness, it's so challenging because in the US, after a patient has had a hip fracture, if they're over a certain age, over the age of 65, let's say, they will be allowed to weight bear immediately. So it's weight bearing is tolerated with the idea and the argument that these patients who have some sort of hardware, who have fixation, so we're not talking about a patient who just has a fracture without any of the fixation, the patients who have, let's say, a rod or some screws and metal in their hip, these patients need to start moving soon because if they don't, there are more complications related to bed rest, more complications related to immobility than there are related to mobility. And so they're getting up and they're walking and they're moving quickly. Whereas in China, obviously, that's not the case. And so what we want you to be able to do is understand that loading for somebody following a fracture is really, really, really important. And for loading after any of these things is important. And we as physical therapists, as trainers, we can help do that exercise and provide manual therapy at the right level so that their cells, so their tissue can actually improve their healing. So you'll see this picture here. If you're loading the right amount, the cartilage will stay healthy and the bone itself will stay healthy. So we need to direct our loading to the right tissues. We also need to think about loading through functional ranges. So this is another piece that we will be addressing, is this idea of what is functional mobility. I've noticed that people here love to focus on range of motion, and it's a real struggle because the doctors will say, well, they can't weight bear, but I need their knee to be 135 degrees of flexion. Well, I understand that 135 degrees of flexion is important to be able to use a squat toilet. But guess what? You can still use a squat toilet with 115 or 110 degrees of knee flexion. You don't need 135 degrees for anything unless you're a plumber or somebody has to get into a small space on your knees. So please recognize that functional ranges of motion are all we need to be able to load our tissue and make it actually heal faster. And so changing your focus from range of motion to functional range of motion to allow for loading to happen is very, very important. And I continue every day to look at therapists who spend their entire visit trying to get elbow flexion. And I recognize that, guess what? Elbow flexion is very important functionally for eating. But once they can get their hand to their mouth, they don't need more flexion than that. And if you really, really want that tissue to heal, you need to be thinking about other things. So I've made that point. I want you to recognize that functional range of motion and loading in those functional ranges of motion is just the most important thing to consider. as well as considering how you're going to provide certain different kinds of loading. So changing the magnitude, the direction, the intensity, as well as this idea of making sure that you're also including mobility of the nerves. So this is kind of a newer concept, but what we've recognized really over the last 20 years, I've been practicing since about 2000. And I would say that when I was in school, we did not talk about nerve mobility. This is something that's relatively new, but very important. We need to recognize that nerves need to be able to move around the tissue and sometimes through the tissue that has been changed with the surgery. And so this idea of making sure that they have nerve mobility and listening to how they report their symptoms and thinking, oh, this elbow fracture, it sounds like they're having nerve symptoms. They're not just having pain from trying to flex and extend their elbow, but they're actually having pain because their ulnar nerve, maybe even their median nerve or radial nerve, have become impinged or just decreased mobility because of this elbow fracture. So those are all things that we need to be thinking about. So, as I said earlier, just to kind of reiterate these considerations for optimal loading, we need to think about the tissue. And so is that tissue something like cartilage, which is what we're going to start with. We're going to start with, like I said, probably the hardest tissue. Cartilage is very, very difficult to heal because of blood flow issues, which we'll talk about. Ligament, also relatively difficult. The healing time frame is much longer than any type of contractile tissue. So our tendons, our muscles are going to heal faster. And then lastly, our bones are also going to heal faster. The other thing we need to consider is acute versus chronic presentation. So sometimes we'll see these patients non-operatively, and we will touch on when you see a patient, let's say after an ACL injury that is not having surgery. We'll talk about those things. We'll talk about things like osteoarthritis, especially with cartilage, and how we're going to deal with those patients who have not had surgery, but also considering those patients who maybe had a fracture of some kind 6 months ago and never had any rehab. And how do we deal with those people? Because those will look different than somebody who had a fracture 2 weeks ago. We also need to consider the patient's functional goals. So I mentioned earlier our patient who's had a hip fracture. And remember, if they've had a hip fracture and they're very young, so let's say somehow they accidentally were hit by a scooter or hit by a car as a pedestrian, those kinds of hip fractures, if you're 45, are going to be differently treated, especially in the West, than a patient who is 75. So with a hip fracture at 75 or 85, their goals are obviously going to be that they want to just be able to get to their apartment, get to the grocery store. Maybe they have to do some stairs. Whereas your 40 or 45-year-old patient is obviously going to want to be running. Obviously probably going to want to be able to help care for children or grandchildren at some point. And so that's just a very different idea of the activity level. And so we need to think about those things as we're working through our rehab. And just continue to keep in mind that optimal loading is early loading. And this, I think, is hard for this culture to understand. And so you guys are going to be fighting with this. And I've said it before and I'll say it again. Early loading is not a concept that's normal here in China. And we have recognized this and it's starting to change. But having good conversations with your doctors and providing them with references that we will provide you, I think and I hope will make it easier for them to understand that the fibers and their surgery. So what I mean by that is they're going to do this surgery that's probably done very well because surgeries are done well in China. They're going to do the surgery and they want their outcomes to look good. And so what's going to make their outcomes look even better is performing early loading, performing rehabilitation in a very strict setting where you are knowledgeable as the therapist or the trainer and you are able to get even better outcomes out of these surgeons' surgeries than they would get without doing rehab. And so that is the goal, is that we want to make that tissue work even better. And so recognizing that adapting to movement and adapting to loading is specific depending on the tissue, and different things like tension, compression, vibration are going to help with that tissue to heal. And that we need to have something called dynamic loading, which helps to reflect the demand of the tissue. So we're going to go into a lot of detail as we talk about each of these 4 tissues, but I'll just introduce this now. With cartilage, you need progressive compression and shear. So you need basically initially just basic movement. You need to be able to pump your ankle up and down if this is a cartilage injury at your ankle, or be able to flex and extend your knee if it's a problem at the knee, and then progressing to having more compression and shear to that same tissue to allow it to heal. Whereas with the ligament, you actually want tension in the line of stress. So obviously initially, when we think of ligaments, we often think of things like an ankle sprain. With an ankle sprain, the first couple of days and weeks, we might not be stretching in the direction of the sprain, but as those ligaments start to heal after just a basic sprain where we don't have a full tear through the ligament, we need to actually put some tension in the line of the stress that you normally would get with a sprain, and that helps those ligaments to heal. With tendons, we also need to put tension and load that tendon. And for those of you who have been doing treatment for a long time, you know, if you've read any research about tendons, that eccentric loading, contractile eccentric loading, we have found to be the best way to help tendons to heal, to help them to lay down those tissues correctly. And lastly, with bone, we want compression, we want weight bearing, we want tension in the line of stress. So we don't want a lot of torsion, we don't want a lot of twisting of the bone, but we do want pressure directly from top to bottom in that bone to allow that bone to heal better. And again, we'll talk about these in more detail later. I just want you to have that basic idea. And so, what do we need to do? We need to start early. We need to make sure we understand the tissue. We need to be progressive. We want to make sure that over a period of time that we are progressively getting more difficult. We can't stop that treatment. So if you are having to stop treatment because the 30 days are up with your patient, make sure you're giving them something to do on their own so that they're not decreasing their activity if you're not treating them. We also need it to be consistent and repetitious. And so we'll talk about the number of repetitions that are needed to help improve tissue. And we also need to allow time for the tissue to adapt. So the question is not whether or not we load, it's how we can do it and provide the correct amount of loading while performing protection. So we need to be able to understand how much load is the right amount of load, because if we don't do enough, we're not going to gain anything. If we do too much, we're going to end up injuring. So we need to recognize these are the goals. For cartilage specifically, we need to protect the healing tissues. But at the same time, we also need to move functionally and allow for the function to happen as soon as possible. So we want to make sure we're following, like I said, that kind of idea of cyclic loading, but also allow for patients to look at their function. And as we work through their rehab, we're considering those functional goals. We're considering, let's say, the other leg. So if this is a knee replacement or a hip replacement, what does the other side look like so that we can decrease the possibility of future joint degeneration? And so these are all things to consider as we do our rehab. And recognizing the most successful outcome is for us to be able to have a functional joint. So that means decreased pain, increased stability, enough strength and neuromuscular control for the patient to be able to reach their goals. So as I mentioned earlier, a lot of the patients who have cartilage damage and are needing surgeries are going to be older patients, and their primary goals are going to be relatively basic functional things. We need to make sure that we can load that tissue, but then also provide the rest that these older people need to allow for them to return to the functional goals that they have. So return to being able to walk to the grocery store, go up and down the stairs. Those are the primary things that we think about, especially related to cartilage. And so lastly, I just want to give you a little bit of that timeline information that we're going to reiterate over and over again through these classes. A huge amount of why different tissues actually heal at different amounts of time is because of their vascularization. So blood flow to the tissue makes a huge difference on how the tissue heals. And so you've often probably seen and wondered about how when a muscle gets strained or a muscle gets pulled, or maybe you just worked out way too hard in a day or two, or your clients worked out way too hard, then they're sore for a little bit of time, but then they get better. And that's because muscle has a lot of blood flow, and muscle can pull out any of that lactic acid or any of those other things pretty quickly to allow for the muscle to heal. However, we have other different types of tissue like the ligament or even the meniscus or cartilage, which has a lot less vascularization. There's a lot less blood flow to that tissue. And so unfortunately, that means that the ligament is not going to become healed quite as quickly. And then what you'll see here in the middle is that we have tendon and bone, and both of those actually have better vascularization. They have better blood flow to them. If you remember back in high school biology, you talked about bone and what it looks like and the fact that we have lots of good blood, red blood cells being developed by bone, but also just good blood to the bones because of those red blood cells being developed. And so bone actually heals pretty quickly and with a pretty easy time frame. So what I want to end with today is the actual time frames that we can consider. And this is something I would say you probably want to memorize because it's important for you to be able to say that, okay, this problem appears to be maybe just a muscle injury that occurred because of overworking. And so with muscle soreness, we know that that will improve very quickly. And even a muscle strain will also improve quickly. So unless it's a significant muscle strain where maybe there was some tearing of the muscle, otherwise your muscle strains are going to get better within 2 weeks. And very little treatment really needs to be done. But I think we've all seen ligament sprains and grade 3 ligament sprain, so a very, 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 very bad ankle sprain, can take up to a year for those ligaments to actually heal. With a tendinitis, this actually says it will take 3 to 7 weeks for healing, but I would argue that you probably can get decreased inflammation within several days with a tendinitis, again, because it has relatively good blood flow. And so I really very rarely see a tendinitis that's going to last for 7 weeks, but tendinosis, you'll see here, can last for 6 months. And obviously a laceration in the tendon or a tendon like an Achilles tendon who's had a repair, those are going to take about 6 months to heal. Whereas you're going to see bone heals very quickly, and bone really does follow a pretty strict time frame. So unless your patient has osteoporosis or something like that, your patient is probably going to heal for most fractures within 3 months. And it's really, really important that people in China understand that, because this is where we have the biggest fight. I really want doctors and patients to understand that by 3 months, pretty much everybody's bones are healed, and we should be able to do what we need to do. Articular cartilage, which will be the first thing that we really go into detail about, you'll see can take up to 2 years to heal. And the same thing with ligaments. So when you think about your patient who has had an ACL replacement, those patients can take up to 2 years, and usually do take up to 2 years to heal that graft for their ligament. So again, I think you probably want to memorize these healing times, these time frames, because it's going to help you out a lot as we talk about all of these things. And I look forward to spending the next videos, the next bit of time talking about these things, and hopefully we can all talk together in the near future. Thank you.